Good evening, everyone. I'm John Lanigan, Dean of the School of Business here at Baldwin-Wallace University, and on behalf of President Bob Helmer and the entire BW family, I'd like to welcome all of you here with a special welcome to BW students. We've got a group of students that are visiting this week from Brazil, and I'd like to also welcome any BW alumni that are here, and then any supporters and guests of the university. Thank you very much for coming. We've got a great program for you tonight. With what's going on in the world of healthcare and health scares, I think this is a very, very timely event. And as we celebrate this Kamm lecture for 2014, we've got two eminently qualified people to enter us into and lead us into a discussion about the current state of and challenges and opportunities in the new world of healthcare. On your seat, you should have this little sheet, and in case you didn't turn it around, the bio for Dr. Akram Boutros is on the back of the sheet, and as you can tell, he is obviously a very accomplished and very experienced healthcare professional, and is doing just phenomenal things with Metro Health here in Cleveland and taking it to absolutely new heights. The only thing on this bio that I didn't see that I found elsewhere was what kind of doctor he is, so I found that. Dr. Boutros is an internist, and he attained his Doctor of Medicine degree at the State University of New York Health Sciences Center in Brooklyn, New York. Our other panelist is Tom Campanella, and Tom is currently the director of our healthcare MBA program at BW, as well as a professor of health economics. Tom got both his BA and MA in economics from Ohio University, and he also has a law degree from Cleveland State University. Tom spent over 30 years in the healthcare industry, specifically with health insurance, physician, and the hospital sectors. And he was formerly a vice president of healthcare finance and care management at Blue Cross and Blue Shield of Ohio and Medical Mutual of Ohio. So with that, I'd like to ask you to welcome our two panelists, and Tom is going to start this off in a Charlie Rose type of format. So if he looks like Charlie Rose or acts like Charlie Rose, it's all in
Charlie Rose.
it's all Dick Cavett, you name it. So let's offer a round of applause for our panelists.
Thank you, John. Hopefully everyone can hear me. With the Kamm lecture, what we really try to do is to bring people both within the BW community and external to the BW community and really discuss and have an opportunity to maybe deep dive on issues that really affect us in the world of Northeast Ohio and our community. And this year, and I think it's quite appropriate, we wanted to focus on healthcare. And the reason why we look at healthcare from so many different perspectives, and we know it from Northeast Ohio, is that, healthcare industry, the sector, and everything else touches us in so many different ways. A lot of you may be employees there. Some of you are in a position where no matter what sector you're in, that you're being touched by it. And obviously on a personal basis and a family basis, you're impacted by healthcare. Because of that, it's even that much more important to be able to see what's not only happening in the past and today, but maybe a little glimpse of the future. And that future obviously has both opportunities and challenges. Tied into that, which I think is quite relevant, is the overall health of the community. Because we're impacted in so many different ways by the health of the community, specifically as it relates to Northeast Ohio. So as we were looking at trying to find an appropriate speaker, really the discussion was pretty short. We really zeroed in on Metro Health and specifically Dr. Akram Boutros. And as John Lanigan told you, his background has been tremendous, but more importantly, as I've had the opportunity to really meet and know Akram, I've had the ability to be able to really see some of the things both on a personal basis as well as what Metro's doing to sort of revolutionize and really innovate and attack a lot of those challenges that we're having in healthcare. So with that, what I would like to do just for a few minutes to go just a little bit, you talked about we had a little overview of your background, but ultimately, what brought you to Cleveland?
BW, no. It's Metro Health. I mean, I didn't know much about Metro Health, and I got called about the search. It was about the time I decided to go back into full-time healthcare management, and two wonderful friends and actually business partners came from Cleveland. So one was a former physician leader of the Cleveland Clinic, Dr. Alan London, and another is a gentleman who ran one of the largest healthcare consulting firm, Joe Davis. So when I called them and I said, hey guys, I'm being called about this Metro Health, what do you know about it? They both separately but almost exactly the same said, Akram, this is so right up your alley. This is what you always talk about, doing, having meaningful impact in the community. It's a great organization, and they are in need of somebody with your skill set. And I said, but it's in Cleveland. And they said, you haven't been to Cleveland for 20 years. You got to look at it. And when we came, I fell in love with the people of Metro Health first. And then I have to tell you, Midwesterners are the coolest people I have ever met. So you guys not only won me over, my entire family, including my three daughters, are 18, 20, and 22, are now in Cleveland.
Good. Well, welcome again. And most people, obviously, especially some of the older people like myself, have a real good understanding of the relevance and the importance of Metro Health. We have a lot of younger students here, too. Could you tell the audience a little bit about Metro Health itself and the overall mission of that hospital and maybe some unique aspects of it?
Sure, I'd be glad to. So you got to go back to when Metro Health was actually started, and for some of you this will be kind of enlightening. So the year that Cleveland was incorporated, Metro Health was founded. 178 years ago, Metro Health was founded due to a health crisis. So there was always a poor house in Cleveland, as it was in every other place. And one of the things that happened, there was a cholera epidemic. They got some vaccines from the US government and didn't know how to distribute it and where to put the patients who got cholera. So instead of keeping it in their homes, they formed Metro Health, which was the poor house, had room. The doctors came, they distributed the vaccine, and Metro Health was born out of a healthcare crisis. Metro Health, some just additional things, we became the first public health system, recognized public health system in the nation. We were as large at one point as 1,700 inpatient beds. It was an immense organization. During the polio epidemic, Metro Health became a very, very critical part of the fight. Dr. Robbins, who invented the process by which the vaccine was eventually created, taught Dr. Salk how to do that. And if you had received the Salk vaccine, it was partly because of Metro Health's research. During the Great Depression, Metro Health played great importance because the vast majority of Cleveland and the surrounding area didn't have enough money to seek health care. So came in, stepped in again, and kept people from leaving the region because we were able to provide that. During HIV and AIDS crisis, we were there. And I think we're, again, playing a really important role in that we think we found a solution to this issue of very high cost healthcare and poor outcomes. So I think we're playing another pivotal role, and this is probably could be as an important role as the role we played in the polio epidemic.
Very good. By the way, as an aside, we will have more than enough time at the end for questions. So as you go through this, if you have particular questions, write them down, and we'll have a mic going around too. On a general level, and I definitely want to get back to where you left off in regards to some of the innovative things you're doing, but on general, from a hospital standpoint, what are some of the key business issues or critical issues impacting hospitals and specifically Metro Health today?
Well, there's a lot of things. The first one is that we're not making headway on health in Cuyahoga County or maybe the nation. So we've built an amazingly successful sick care system. That means if you have a problem, if you already get a problem, we can fix it like nobody else. No one else in the world can do as good a job as we do, and that's really evidenced by that the people who have the greatest choice in the world. People who have all the money in the world get their health care here, right? Well, that's because something has already happened to them. But if you look at, for example, Cuyahoga County, our healthcare outcomes are 65th out of 88 counties in Ohio, and Ohio is 40th out of 50 states in the nation in healthcare outcomes. So despite an unbelievable sick care system, Cleveland Clinic, if you have coronary artery disease and no one will operate on you, they can fix you. There is no better than Cleveland Clinic for providing that service. If a child has a rare tumor, Rainbow's Children's is unbelievable with it. God forbid you have trauma, a massive trauma, and are hanging on to dear life. Metro Health can give you that opportunity to live. And we reduced the mortality rate in Cuyahoga County by about 50% in the past 3 to 4 years. So this is an amazing town for sick care. We just don't do enough to keep people healthy.
Well, given that, the focus, when you think about it, the focus on evolving from a sick care system to a health system is a classic win-win. Win, obviously, for the patient, where they, in effect, do not get sick in the first place. Win for the payers, anywhere from the government, Medicare or Medicaid, employers that are trying to pay it, and again, consumers. And ultimately a win for the community. So given what you're saying, what needs to be done, and specifically what are you doing to address some of this population health or trying to focus on the overall health of our community?
So we have a reimbursement system right now that actually penalizes you for doing all of these things. So if you reduce the number of admissions, there is no reward for you. You just get less money. If you try to move some of the healthcare dollars into solving social issues, actually you're run afoul of things called the laws that kind of prevent people from recruiting patients. Okay, so if you try to take some of the healthcare dollars and say, I will solve this patient's social issue, which will have them come to the hospital and use less services and maintain health, we actually have most of the laws look at that as you're trying to recruit patients, and therefore it's forbidden. So one of the big things that we're looking at to solve this problem is to look at a new reimbursement system for ourselves. So we're moving very quickly towards a risk model, where we will assume the total cost of healthcare for a specific population. That will permit us to move money any way we want to, and move a lot more of the money towards what turns out to be about 70% of the determinant of your health. Okay? So 70% of the determinant of your health is your behavior. We got static?
Let's move the handouts.
Is this better?
Yeah.
All right.
This is better.
Okay. So if you look at how do you what are the determinants of your health? There are kind of four major determinants of your health. The first one is your biogenetics. So thank mom, dad for whatever ailments you have and whatever good things you have. I have a 90-year-old dad and a 87-year-old mom who are continue to be active. So I can eat all I want and my cholesterol never goes up. It is unbelievable, and I thank them for that. Okay, so that's a really good thing. So for you, you will have all of this comes from your parents, and that's about 20% of your health is determined by your biogenetics. 10% is your environment, where you live, all the different things that you have. 20% is the care you receive from birth to death. Only 20%. That leaves 50%, and 50% is really these social determinants that happen to be behavior and lifestyle modifications that you are looking at. So we spend very little time doing that. We spend very little time in the environment, and we spend obviously in biogenetics is being taken care of by somebody else, and we focus all our attention on after people get sick, we provide services for them.
Well, given that, for an example, let's get a more specific. I know one piece of data that I was able to look up was that black babies born in Ohio are twice as likely as a black baby born in the state of Washington to die before their first birthday. And then what I wasn't aware of, as I got into the data a little bit more, they really sort of separate that first year in regards to a child. And this isn't just, by the way, a state of Ohio issue. This whole infant mortality is obviously a national issue, especially when you compare us to other countries in the world. We don't rank too well for a lot of reasons. But they further break it up where a child that dies before their 28th birthday is called a neonatal infant mortality, and those that die after their 28th but before their first birthday is the post-neonatal. And there's specific reasons.
He means 28 days.
28 days.
Okay, yeah,
Sorry.
28 days. Yeah.
28 days, sorry. But the point is, when you go through this, there's obviously reasons for it. What are you doing proactively to be able to address issues like that?
Okay, so let me just give you some additional statistics and background that I hope is helpful. So if you look at infant mortality, for example, for Ohio, it is 15.45 infants out of 1,000 who die before their first birthday, okay? For non-Hispanic black infants. If you look at a state that has done a good job with it, that is Massachusetts, it's 6.34. So it's 40%. There's been a 60% difference between us and Massachusetts. So there is no difference in biogenetics or anything else for non-Hispanic black infants here and Massachusetts. So it's all that 80% that we were talking about, the care they receive, the lifestyle and behavior of the mom and the environment they're in. So that's what accounts for that differences. But just so you're aware also that according to the Kaiser Foundation, the likelihood of death for a non-Hispanic black infant is 2.3 times that of the non-Hispanic white baby in Ohio. 2.3 times. Okay, it's pretty remarkable, the differences. So we definitely, on both sides, can show that intervention can make a difference. So, for example, 2/3 of the neonatal deaths, that's in the first 28 days, is 2/3 of the deaths happen in the neonatal period, and most of them are due to preterm birth defects and maternal health conditions. So we've done a lot of different things for both on helping high-risk moms and also looking at preventing preterm birth. And I'll tell you about that in a minute. On the other side, the babies who are over 28 days, there are 4,000 babies who die a year in the U.S. who are between 28 days and their first year. And most of it is due to sudden infant death syndrome. So, very simple thing. Since 2004, we've been looking at reducing that, and we looked at a program called ABC. Okay? The ABC program, you would think, is universal, and everybody knows about it. And ABC stands for always have the baby sleep alone. That's the A. Always have the baby sleep on their back. That's the B. And always have the baby sleep in a crib, not in a regular, not on the couch, not on a regular bed. By doing that, you reduce this type of mortality by 50%. It's a fairly simple thing to do. So we've made some strides in that. So what does Metro Health do? Well, we offer a prematurity clinic for pregnant women at high risk. We have a fetal care clinic for women who have babies with already known fetal birth defects, so we can help those babies have the greatest chance for survival. And we're doing something pretty cool by going into the schools now and working with young mothers, teen mothers who are pregnant. And instead of us waiting for them to come to see us, we're making the first steps on going to see them. And we're having conversations that are a little bit unusual. We're asking them to actually verbalize this, and we ask them, would you like to have a healthy baby? And the reason we get them to verbalize it is because it is a form of a social contract. We're not imposing something on them. We want to deliver the care they need. And as soon as they say, yes, I would like to have a healthy baby, then we say, okay, well, here's what we need to do to have the baby healthy. This is what you need to do, and we'll take it a couple of weeks at a time and make sure that we're delivering the services to you, that you're keeping your part of the bargain. And some of these young ladies are on drugs, and we don't say to them, hey, you're a drug addict, you need to stop doing this. We say to them, okay, the highest risk for birth defects if you're taking drugs during the first couple of months. So why don't we work in the first couple of weeks you're staying off drugs? That's it. And a couple of weeks go by and we say you've done really a good job. Let's shoot for a couple of more weeks. And lo and behold, some of these young ladies never go back on drugs and actually have very healthy babies. So if you look at Metro Health neonatal ICU, our volume is dropping because of all the things we're doing. And instead of having a child that literally costs $1 million for them to leave our ICU, it costs about $5,000 for a normal kid to leave our hospital. It's a pretty good return on investment. But as I said to you, we don't get that money back. We literally go from receiving $1 million to $5,000. There's nothing financially rewarding for us doing this. It just happens to be the right thing to do. And then for the post-neonatal period, we do a lot of different programs, from comprehensive care to pre-clinic to sleep on back to sleep campaign, which is like the ABCs. And we have a mother and child dependency program to help moms stay off drugs and also breastfeed the child and all sorts of things. So lots of things.
Now, given that, going back, because at one point you said is critical, is you have a mission, you have employees, you want to survive to be able to do your mission. At the same time, we have, on an overall basis, historically, a payment system from both Medicare, Medicaid, and managed care health insurance that basically says, as you said, it's tied into a sixth system. So the more you do, the more you make. You mentioned about, and maybe you want to talk further about this risk contracting, because the concept of risk, I would think most providers would want to stay away from risk arrangements. What are you doing differently?
So one of the attractions for me for Metro Health is the way they practice medicine, and been practicing medicine way before I got there. So is that they have they've had very limited resources, and they've had lots of patients. So they had to figure out, how do you really provide the most care for the least amount of money? So when I came around and I looked at the financials of the hospital, one of the things I looked at is their cost structure, and I did some analyses, and it turned out that Metro Health breaks even on Medicaid. I have never in my entire career come across any hospital that breaks even on Medicaid. Most hospitals are been trying to break even on Medicare, and Medicare pays us about 15% more than Medicaid, 15 to 20% more. So I came around and I said, you know, this is real strength. And so I you know, Tom, you know this because we've spoken about it multiple times. I don't approach these issues like most of my colleagues do. I approach it with a very simple question. What's the right thing to do? We're not going to discuss anything else until we discuss what's the right thing to do for the community, for the patients, for the organization. Once we figure that out, then I know we have the brain power to figure out how to do it right. So we figured out that the right thing to do is for us to invest in all these different programs. So we've decided to do that. Then we've said, well, what's the way for us to finance this? And we said, well, the only way we can finance this is if we get the majority of the healthcare dollar for that population. Then we can shift this money all around, and as we reduce hospitalizations, as we reduce ED dependence, as we reduce all of these different things, that money is going to be retained in the health system for us to invest in more things. So I will give you an example. We had a program called the Red Carpet Program, in which we took 140 patients, that MMO patients, who were spending about $60,000 a year. $60,000. And we said, okay, let us figure out a way to take care of them. We put in different parameters for care for them. We assigned them to a care coordinator and nurse care coordinator who really got involved with their lives. 1 year later, we saved $5,000 a patient. Unbeknownst to us, Metro MMO identified secret twins. These were patients very similar to these patients who were not in this experiment. Their cost of care at Metro Health went down by $300. So we know the intervention of keeping a patient healthy can provide rewards. So as a result, we're sharing $300,000 worth of savings. So that's what we're doing. We're moving towards risk, and what risk says is that instead of being paid for something we do to you, because we do a lot of stuff to patients, we want to be paid for keeping you healthy and keeping you well control of your disease, and helping you manage all the social determinants.
So a key component of that then would be patient compliance and education. How are you addressing that issue?
The first way is we stop blaming the patient. It's pretty remarkable how often we blame people. Well, they didn't come for their appointment. That's not my problem. If the patient is really the customer, it's our job to make sure that there's no reason for them not to come. It's our job to fix these things, fix all the obstacles. So our nurse managers, our nurse coordinators, for example, care coordinators, do that. They find what the problem is with Betty Sue, why she can't keep coming. And instead of yelling at her and saying, hey, this is your fault, you got to figure out how to get here, they actually find out why she can't get here and find a way to have her get here. Instead of throwing pills at the patients and saying, here, go figure it out, and I dare you to go find a 65-year-old patient who was hospitalized, who got new medication, who actually, as soon as they leave the hospital, I dare you to go talk to them and find somebody who actually knows what medication they're supposed to take and knows how to take it. I can tell you that because as a physician, when I was hospitalized and I got all my new meds, I had to go back because I had no recollection of what they told me. Okay, so, but we leave patients on their own. We go, here you go figure it out. So we're going in and are sending people in right after discharge. These patients have these critical events and saying, okay, let's take your pill box and let's clean out everything else and put the right pills in place. I'm going to give you a really terrible statistic. We became a Medicare ACO, and that means we're taking risk for 10,000 patients. 100 patients of ours last year used $22 million worth of care. 100 people, $22 million bucks, and they're all alive. $220,000 a person. So, don't you think we should know who they are and make sure we take really good care of them? Because I think I can put you at the Ritz-Carlton with a physician 24 hours a day and a nurse 24 hours a day for less than 220 grand. So we began identifying them and actually doing interventions. And so far, we've done serious interventions for about 15 patients. And the data is just remarkable. So they have an average of 3 admissions a year and about 10 ED visits a year. As soon as we begin with care coordinators, out of that 15, now it's been about 4 months we've been doing this, only 1 patient has been admitted. And for the other patients, they went down, for the emergency room visits, they went down by 70%. So we have ways of doing it. We just got to be able to mass customize your care. So your care is going to be different than my care, and we got to mass customize that care to every individual.
Could we, as we focus, touch 2 other areas that are, from a population health, community health, that are pretty critical? And just to give, again, a sense of what Metro Health is doing. One is childhood obesity, and the other one is mental health. And as you know, the linkage between the mental health and the clinical side is very high. And what proactively are you doing to address those 2 issues from a population standpoint?
So we have a program that took obese children and taught them how to garden, taught them how to exercise, taught them how to do so many things, and they've shed lots and lots of pounds, are getting much healthier. You know what the cool part is? So did their parents. As their parents saw these kids doing really positive things, they began influencing them. So we didn't count on that, but it's happening. And We also have a grant called HEAL that we're trying to, that just finished, but we're trying to institutionalize it. We want to be able to take kids very early on and be able to give them lots and lots of reasons to stay healthy. So getting them engaged in community gardens, getting them engaged in helping others exercise. The kids love taking other people on exercising. They forget that they're exercising themselves. As far as mental health is concerned, take whatever chronic disease a patient could have, give them depression or other mental disorder, and it will cost twice as much to take care of that patient. So we do lots of interventions for these patients so that we can know we can keep them healthy, we can keep them out of the hospital, and we can keep their healthcare costs low. We're also doing some unique things. For example, it's going to be announced by Medicare. We're about to become the first hospital in the nation to pay for a medical legal clinic for some of our Medicare patients. So that means they come in, they tell us what their issues are, and then we find out if there are problems the legal systems can help them with. So for example, some of these folks live in tenements, and Metro Health can't do much about it, but legal aid can. So we actually found a cluster of patients who have respiratory illnesses, and we think it's all due to mold. And I can't do much about mold, but the legal system can.
Well, tying into the collaboration point you just said, obviously when you're talking about a community, there are various stakeholders from a healthcare standpoint that are also involved in the community. I know, for an example, from a hospital standpoint, as relates to tax exemption, there's a community benefit concept, and that focuses on also one of the ideas is, to be more involved in the Affordable Care Act too,
right,
in regards to population health. And then you mentioned, I think, two things. One, obviously the collaboration with the legal aid, and also earlier you talked about collaborations with the schools. Could you just talk about in general, because obviously Metro's doing a lot, but what kind of other collaborations are you doing? Because in a community, people aren't just, sort of linked in with one player or another, or one stakeholder or another. How are the stakeholders all working together? Or maybe they're not?
So from a hospital perspective, we are doing collaborations, for example, with the clinic on the trauma program, Cleveland Clinic with the trauma program. We have one regional trauma program, and as a result, we've been able to reduce, as I said, the mortality rate in Cuyahoga County by about 50%. We just came together for the second of its kind is a stroke ambulance, so that if a patient has symptoms of stroke, the ambulance goes to them, this specific ambulance goes to them and actually does the CAT scan at the patient's area. So let me tell you a funny story. Now, I don't know if it's funny. I don't think the gentleman would think it's funny, but he came to see me yesterday. I was over at Fire in Shaker Heights having lunch with my daughter when somebody said, is there a doctor in the house? And the gentleman who was having lunch there was having a stroke. So I went, I took care of him, helped lower his blood pressure. We called the clinic ambulance. They came, we did the CAT scan. We know exactly what he had. He got into the emergency room. They knew exactly what the results were, and they had already contacted the neurologist. He was giving the treatment, was in the ICU for 6 days, came to my office 4 weeks later to tell me how great he's doing. He's getting back to work on Monday. Now, when I first saw him, he was completely flaccid on the left side, could not move anything, could not speak. He came to see what I looked like. I was with him for over an hour, and he has no memory of what I look like. And I said I would be happy to send him an 8.5 by 11 glossy, but he wanted to see the real thing. So we're doing these kind of collaboration, and in the school system, for example, we're trying to get every one of the 100 CMSD schools covered. Metro Health is committed to covering 23. Cleveland Clinic is working on covering some. UH is working on covering some. And the federally qualified health centers are working on covering the rest of them. So we're trying to have, look, competition in the healthcare business, in the business side, is good. Competition in the provision of community care is absolutely terrible. So I was with Dr. Cosgrove, Mr. Zenti, the CEO of Sisters of Charity, and CEO of Akron General on stage a few weeks ago. And I was asked, how do we promote collaboration? So I told them the truth. Get the CEOs out of the room and let the providers figure it out. If you leave us out, the providers can figure out how to collaborate.
Some people nodding their head out there. So, given that we have, an overall community, one of these, since in 2010, we had something called the Affordable Care Act passed. And as you know, that's been subject to a lot of political debate for various reasons. I'm curious from your perspective, what are your thoughts both on, did it need to pass, was there a need for it, and how has it impacted Metro, and what are your thoughts overall?
So the law is amazingly cumbersome. We don't know what the unintended consequences are going to be. But as far as the intent of the law, I don't think anyone can argue with the intent of the law. Giving care to people who need it, making sure it's done with in a more accessible way, with better outcomes at lower cost. How can you argue with that? Now, the problem is the law is 200 pages and has 2,000 some odd regulations associated with it. So who the heck knows how it's going to come out? We were not having this conversation about risk or anything else before that law came into effect. So if you're talking about changing our focus, we are not going back. Population health is here to stay because of the Affordable Care Act, period. Now, what does it mean to Metro? Metro Health payer mix, I'm looking at the clinic's revenue person, is almost every CEO's nightmare. We have 45% of our patients are Medicaid today, even after the Affordable Care Act. 10% are still uninsured. Everybody thinks ACA covers everybody. It doesn't. So that's 55% are Medicaid or don't pay us. When I was in New York and I went from 4% to 6% Medicaid, I explained to my board that that was eroding our financial structures and I would have to cut programs. Now I live with this reality: 55% of our patients are Medicaid or free care. And then we have about 22% are commercial and about 20% are Medicare. So if we were, for example, if Metro Health, we made $19 million last year, if we had the same kind of payer mix as the two other health systems, we would have made $140 million. So one of the reasons Metro Health is critically important for this is that we got to show that you can actually do this and be financially stable.
Well, given that, because I want to leave enough time, so I only have really one more question, for questions from the audience. But obviously then, as you said, the cost side, the seamlessness, the communication side has to be critical for you to be able, given that mix, to be able to survive financially.
Right.
And put you in a better position then to be able to want risk, like you said, and also do well with healthcare managed care companies, you know, in regards to negotiations and,
Right.
and doing well. And that's sort of a message I think, again, a lot of people can learn from. Do you have any, you know, before we get into the questions, any final points that you would like to get across to the group?
Yeah, I don't want to tell you that we figured it out and we know how to do it. We have major challenges. One of our major challenges, for example, is our patient satisfaction scores are horrible, just absolutely horrible. So we need to get that better. We need people to understand. I want to treat people, and I tell all my staff this: please do not treat people as they were your relatives. I want you to treat them as if they were my relatives, because I know my wife and children and parents get incredible service. I don't know if you like your relatives or not. So as far as I'm concerned, treat them as if they're my family members. And people to this date, I had a gentleman call me on the phone this morning crying because he sent me an email and he said he's been having a problem with our health system for the past 3 weeks, and I got it resolved. He sent it to me last night. By this morning it was resolved, and he called me to say thank you. And I said, you know, you don't have to thank me first. That's my job. I wish you didn't have to do this, but thank you for bringing this to my attention, because that problem, they actually by this afternoon have a system to make sure it doesn't happen again. His wife moved from a job and is now on COBRA. He doesn't have his COBRA card yet, and Metro Health requires you to go through financial assessment before we make even an appointment for you. He says, I'm willing to pay for it cash. I just need to see my doctor. My wife needs to see her doctor. And we said, well, we don't have any way of doing that for you. So, well, as of this afternoon, we do. We have a way of doing it for him. So we got to resolve people's problems and stop being so bureaucratic. I tell people again, figure out what the right thing to do first is, do it, and we'll figure out how to do it right afterwards.
Okay, questions from the audience? We'll circulate this mic. Okay.
After you keep yours.
Yes.
I can be really loud. Why don't you take the other one too, and can you guys hear me in the back? All right, cool. I'll talk like I'm speaking to my 3 daughters.
Don't listen like they do, though. Okay.
First of all, Dr. Bruce, thank you for the forum, and thank you for the information, and thank you for being a huge backstop provider in Cuyahoga County, because without Metro, it doesn't happen. Here's my question. We got this huge initiative as part of the ACA called electronic medical records, right? And they're adding a ton of value inside the clinical setting. But now we wheel the patient to your door, we put them in the car with their family member or their friends, and we send them home, and the EMR doesn't go with them. How are we going to coordinate and manage care with all the backstop providers beyond you in the community? How are we going to link them all together and use that care coordination that you've built? How are we going to do that?
So we actually, through our Epic system, we have something called Care Everywhere. So any physician who's taking care of any patient who's been at Metro Health can actually access their entire medical record. So it doesn't matter. You could be a voluntary physician. You could be actually in Las Vegas taking care of our patient. And through Care Everywhere, you can actually access the medical record. The clinic and Metro Health, because we both have Epic, we share all our data. So if a patient comes to one of our services and we need to look at what's going on, we actually share it. I have it on my phone. I have my chart. I literally can look at all my different things, all my charts, all my medication, everything that I've had, and I can show it to my doctor. So we need to make that much more robust, and we need to get that. Now, for us, we've decided all the care coordination, anything that those nurses do, anything that coaches do, has to be put in my chart, because we want it mobile with the patients as well. Epic is coming next week to Metro Health. We're celebrating 20 years. Metro, and again, before me, Metro Health became one of the most committed providers to electronic medical record. We just received level 7 HIMSS recognition for inpatient. We became the first public hospital in the nation to do that. And we're about to receive for the outpatient. No, it's the reverse. We got outpatient, we're about to receive it for inpatient.
Other questions?
Yes, young lady back there.
Yes.
Hi, sir. Thanks so much. I guess my question is a little bit more about the social determinants of health that you were talking about. And you mentioned a couple of the programs. But since you are the level 1 trauma center in the area, could you speak a little bit to any programs that you have surrounding violence prevention, that kind of thing, and trauma, making sure that those patients are actually cared for after they leave, or if they don't make it through the ED, what happens? And then talk a little bit about the funding and what kind of research comes out of your programs as publishable, so more funding can come to the hospital.
So we initially focused on managing the patients who come for trauma. How do you reduce the mortality of that? How do you get them well? So we did a lot of research on that and published it. We're now focusing on 2 areas. I think we have a responsibility with gun violence, because we see every gunshot wound that comes in to the hospital. So we're actually talking about creating legislation to help us, and I don't know if we're going to be able to get it passed or not, but we want to create a period of amnesty after a shooting, that we have one of these mobile gun amnesty programs. Because I think during that period of time, if you have a gun and you live in that neighborhood, you have 2 choices. You can see that it creates enormous harm and give it away, or you can pick it up and shoot someone else. We want to give those people the opportunity who want to decide to make a change, the ability to do that. And we want to do it around an event. So we're actually trying to draft legislation that's going to permit us to do that. We had a large business have one of their drivers killed, another driver significantly injured because of drunk driving. That afternoon, I met with the CEO, and we've committed to $60,000 of funding to be able to help in reducing drunk driving around here. And we're going to do that through our school-based program. So there are enormous number of opportunities to reduce the trauma. We would like to go out of business with trauma.
Other questions? I think there was one right around here. Do we have a mic over here?
Oh, just stand up.
I can speak on it.
Okay.
Okay.
If you could talk about there's a lot of energy around the new main campus and renovation and rejuvenation of main campus. I'd like to know, frankly, what that physical plan means to allow you to maintain or reach some of these goals and initiatives that you're talking about. What about the existing facility keeps you from trying to get where you're going?
By the way, if you have a question, raise your hand and they'll give you a mic so we can keep it moving.
So that is one of the most interesting questions that you could ask. What does the physical plant have to do with keeping people healthy? Right? I think it's a great question. Why are we doing this? So we're not doing the physical plant specifically to address the ACA and the way we're providing different services. However, it presents an enormous opportunity for improvements across all sorts of things. So let me give you an example, and I know this is going to sound very socialist, okay? You cannot combat the cost of health care without combating poverty. 60% of kids in who go to CMSD schools are, on a daily basis, are food insecure. If somebody's worried about where their next meal is going to come from, they're not going to do well in school, they're not going to achieve. There's nothing positive about it. So one of our things that we've decided on the main campus in the renovation is to make sure that the vast majority of the money that we spend is spent for, and the work that gets as a result out of it brings value to people who live in Cuyahoga County. We're actually ensuring that the dollars we spend, the workers in Cuyahoga County actually get those dollars. So we think, just from an economic standpoint, we're going to improve the economic level around us, and that's going to help poverty and help reduce healthcare costs. But we also, in the design, we're designing it so that our staff stays healthy. We're figuring out, believe it or not, we are can connect to the towpath. So we're designing our campus to connect to the towpath and be able to give people lots of opportunities to be out there. We're creating opportunities for patients to be in an environment where just introducing light to them reduces the length of stay in the hospital. We're on an ambitious project, and I'll tell you about it. We're really doing terrific progress. We're not there yet. We have the elderly tend to get an infection called C. difficile. It has a mortality rate of up to 35%. My mother-in-law died from it. Okay, so I'm on a mission to eradicate it. Metro Health, it turns out, had nothing to do with me, but mainly because of Dr. Connors and the work that the environmental services workers on our staff do, had a very low infection rate and very low level of C. diff on surfaces. We instituted a new program of looking at the environmental services workers as healthcare professionals. These are the people who clean your room. So far, we've had 5 months in which, after a patient with C. difficile was in the room, they came and cleaned it, and then we took cultures by an independent person, not by us, by an independent person, of all these rooms, and there was 0 rooms contaminated. We want to eradicate C. difficile from hospitals. We want to become the first hospital to do that. There are some changes that need to happen. For example, on patient beds, we need to line the buttons with copper because C. diff doesn't live on copper. So there's lots and lots of different opportunities in the design to keep people healthy and to reduce the risks.
I think there was a question in the last row.
Doctor, thank you for the good work that you do. You mentioned that you have an opportunity to improve patient satisfaction. Can you speak for just a minute as to why your patient satisfaction numbers lag and what you're doing to address that issue?
So there are, if you look at the components of patient satisfaction, we've done really well over the past year and a half. We've improved significantly. The big number that we look at is, one is your overall satisfaction, and that turns out to have to do a lot more with the reputation of the hospital than it really has to do with the specific areas and the scores you get in these specific areas. So how many people have seen our new commercial? Oh God, just please raise your hand, make me feel better. Oh, all right. So a few of you have. If you see them, I'm going to ask you to pause at the end and see what your face is doing. I'm hoping you're smiling. Okay? That's a big part of changing our numbers. If you are happy, if you think the organization is doing good things, you're going to give us better numbers. The other thing is that we instituted, and I can tell you this, we're the only organization in the country to have successfully done this. Every employee went through a 3.5-hour patient experience training program. Every employee. Every board member, every volunteer, every new employee does it. Okay, so we were able to get 100% of the population done in about 7 months' time. And the reason is we need to do it is because even though we do a really good job caring for people, we forget that they have other lives. So we had a mom whose child ended up dying, and she said the care that her child received in the hospital could not have been any better. We didn't keep her informed as well as we should. So enormous amount of anguish around, did we tell her how things were going in time and all of that. And when you talk to the nurses who are involved, they cry. Because they said, I was doing my job, I didn't pause enough to think about this mom as if she was me or she was my mom. So frankly, we really want to just take a moment and just remember people are people. And sometimes you'll find out I drive my HR department crazy because I hug everybody. Okay, I hug employees, I hug visitors, I hug patients, and many times I will ask them, would you like a hug? But there are parents that I see and other folks waiting in the waiting room. I'll just go up and give them a hug. We just got to remember they're people. And they're really scared. Hospitals are a really, really scary place.
Got a question over here?
Yeah, I just had a question on reimbursement. With you guys being so tied into the Medicare and Medicaid and Ohio being kind of a test ground for these dual eligibility programs and the Medicare where the programs are going to be elected for them, how's that going to impact you, and do you see that kind of trickling down to the commercial payer side?
Yeah, so
You may have to explain.
So they're Medicaid dual eligible. So for Metro Health, about 5% of our population are dual eligible for Medicaid and Medicare. That's the really, lots of money are spent on these patients, and they're moving them into a managed care. They were right now in a fee-for-service world. They're moving into a managed care area. We think that is an opportunity because they're highly complex patients. We think it's an opportunity of actually figuring out how to care for them. So we're trying to work with both the governor's office, on the state level, and with the managed care companies to say, let us help you manage this population better, and have quality metrics for us, have patient satisfaction metrics for us, and the better we perform from that quality, from the outcomes, and from the financial side of it, you got to share the money so that we can invest it in additional programs. And so far, a lot of receptivity for it.
Other questions? One more. One more, so I'll wait back there.
What you're doing is great work. And by the way, I'm a former Metron, so I used to work there years ago. But this is very labor intensive, what you're doing. The nurses, the case managers. How are you getting buy-in, and most importantly, getting more physicians and healthcare providers, whether they're nurse practitioners or physician assistants, into this model that you are creating? Because there's such a resistant group of folks.
So,
and also, where are you finding doctors to come on board with the doctor shortage looming?
So you got to remember, I did 25 years of healthcare management in New York. So here's what I tell my docs. The most obstinate one of them at Metro Health doesn't compare to the regular average physician I worked with in here. And it is absolutely the truth. So Metro Health docs were the first folks around to do patient-centered medical home. So here is what me being a physician does that's actually good. I don't accept nonsense from doctors, nurses, from anybody. I don't think any of us are God. I don't think you're special in somehow. We're just well-trained. There's nothing special about us. We're people like everybody else. So when somebody says, I am not doing that, I'm a surgeon, I'm a neurosurgeon, I'm not going to go pick my patient up from the waiting room and having a conversation with them. There are other people for that. I go, really? Really? You really think you're above speaking to a patient? Do you want me to lock you up and lock you in the OR and that's all you want to do? No. I'm a doctor. I go, well, why don't you just be a doctor? So from my point of view, there are very frank conversations with our medical staff. As far as nurse practitioners and advanced practice nurses, and PAs, they are really critically important to the success of our organization long term and success of this country. They have a certain skill set that gets them really involved with people. They can address multiple social issues. Until medical schools change their curriculum, we're going to have to continue to be dependent on advanced practice nurses because they know how to do it much, much better.
Dr. Boutros, thank you very, very much for taking the time to be with us tonight.